Our next speaker unfortunately couldn't be here in person, so she's done a recording for us. I'm sure Dr. Joanna Hikaka won't be a stranger to many of you, but just to introduce her again, Dr. Joanna Hikaka is our latest and newest interRAI Associate Fellow from New Zealand, and she's a Senior Research Fellow at the University of Auckland and also Co-Director of the Centre of Co-Created Aging Research at the University of Auckland. She's going to share some of the previous findings from other knowledge exchange events around exchanging knowledge and building collaborations. So fingers crossed the tech works. Let's have a look.
Kia ora koutou, ko Joe Hikaka toko ingoa, he uri ahau no ngā rohine. I'm Joe Hikaka. I am a pharmacist and health services researcher based at University of Auckland, Waipapa Taumata Row, and I'm also a co-director for the Centre for Co-Created Aging Research at the university. I'm sorry I couldn't be there today, but I have managed to hopefully successfully record this presentation. And it's, thank you to interRAI Services for the invitation to present today, and thank you all for being in the room. I really wanted to take the opportunity to talk about the knowledge exchange and the collaborations that have come out of the knowledge exchange for me personally. And so you will actually hear the names of many people that are in the room today when I talk about these collaborations. And thankfully, even though I'm not there in person, there will be people in the room that can speak to the 3 different projects that I'll be talking about today. So kia ora. So the knowledge exchange, this is obviously the 5th knowledge exchange. This is the 3rd knowledge exchange that I've been involved in. And when I was thinking about, the concept of exchange, it's sort of the act of giving one thing and receiving another. And so I really wanted to present this to encourage everyone to think about collaborating and networking and trying to move some projects forward. You'll meet people that you haven't met before today. You'll meet people that you know well, but may not have realized the different work that they've been working on and the fact that, it really aligns with what you're doing. The 3 projects I will talk about today arose from the 2023 interRAI Knowledge Exchange. So this was the first knowledge exchange that I had been to, but I had been involved in sort of interRAI related research prior and involved with the research network prior. Now, the first project I wanted to talk about, and shout out to Rosie Gibson, who will be in the audience, is this paper. It relates to the work in this paper that was called Changes and Indicators of Wellbeing on Moving from home to long-term care for Māori in Aotearoa. And it was a retrospective cohort study. And this came about, I have an HRC postdoctoral fellowship, and I really want to explore older Māori and Māori whānau experiences and expectations of aged care. And a lot of the discourse we hear around Māori and aged care relates to the fact that Māori don't utilise aged care. Māori look after their own whānau at home. And so sometimes there's sort of negative associations with aged care for Māori because of this idea that culturally it's not what is done. And there's maybe not so much talk of the positives that can come out of the support that people get when they move to aged residential care. And so I watched Rosie present at the 2023 exchange, and we were having a bit of a conversation. Rosie and I knew each other well through the New Zealand Aged Care Association. We were both on the early career researcher group of that association. And I would have loved to work with Rosie, and we were just talking, and Rosie had talked about the work she was doing within the Awesome study, and as part of an HRC Emerging Researcher First grant and looking at that trajectory from being at home to long-term care. And I talked about my desire to give people, Māori a bit more information about the changes that might happen or the changes in wellbeing that might be supported and facilitated on moving to aged residential care. So we worked together along with our other co-authors, some of whom will also be in the room, to write this paper. And analyze the results. And Rebecca and Jen actually did the analysis for this work. So the key takeaways from this work were that for Māori, when they moved from being at home into aged residential care, there were significant improvements in measures of fatigue, there were fewer falls, there was better sleep, and there was less loneliness. There were noted to be higher rates of depression, and these findings were really a starting point for conversations about aged residential care. So what we had to be careful to do and sort of how we contextualised and framed the results was not sort of saying that whānau were doing a bad job of supporting people at home. So for example, people could present that, well, if Māori had more falls at home, maybe the care isn't as good. But we were really wanting to sort of just have this as a starting point of a conversation. And on the flip side, in terms of higher rates of depression, we do know that for Māori, depression is underdiagnosed in the community. So this finding could speak to the fact that there's better oversight and diagnosis of depression in aged residential care for Māori. But again, it could mean that Māori are having lower mood moving to aged residential care. And both are probably true for different people. So it was really just a flag for people to be thinking about and maybe for the sector to be thinking about. And I'm sure many in the aged residential care sector already think about supporting people in this big life transition. So thank you to all those involved in that project. And as I said, it arose from just a quick conversation at a morning tea that we followed up with afterwards. The second topic I wanted to talk about was developing a national research agenda for interRAI related research. So at the 2023 Knowledge Exchange, we asked people to discuss and document their research priorities, and also facilitators to improve their abilities or the abilities of interRAI related resources so that they felt more able to undertake interRAI related research. So we had over 130 people at the 2023 Knowledge Exchange, many of whom contributed their ideas. And then as a team, we developed sort of a national research agenda, which was published in JAMDA. So thank you to all those co-authors, Dr. Amy Chan, Dr. Bridget Meehan, Gabe Stent, Hamish, Nairi and Gary, who you will see today. So we published that and we really wanted to talk about the research priorities and also sort of like a benchmarking. So these are where we think we need, the priorities are now, and it serves as a sort of an agenda that we can work towards. We know that nationally these concepts and research ideas are important, but it also serves as a bit of a benchmark. So in 10 years' time, we can look at where we came from. The image at the bottom right just gives you one example of how we've laid out the priorities. So we talked about the research priorities and there are different domains, and then the topic or activity or research question relating to that subdomain. And I just sort of randomly got one of the top things that were listed. And then it was funny because as I was looking at what I was presenting today, I realized that it was sort of addressing those priorities, and I hadn't gone back and actually looked at the sort of research agenda, but it obviously informed how we'd sort of moved through some different projects. So, for example, 3 of the priorities that were identified was to identify clinical populations that aren't currently accessing interRAI assessments and explore ways to increase engagement. Explore the potential for Māori engagement with interRAI assessments when lay people complete assessments rather than health professionals, and pilot the use of the interRAI checkup self-report tool, and I will go into that soon. And so many of you in the room will have contributed to this agenda, so thank you for that. And I do encourage people to have a look at that and see if there's any other topics that appeal to them that they have skills and interest in, and they could potentially use that as a starting point for collaboration too. Now, the majority of my presentation today will actually talk about this project, which was a non-randomized non-controlled intervention study where Paiarahi or whānau order navigators supported the completion of an interRAI checkup self-report assessment. So this image is an image taken from one of the geothermal, I guess, springs in Rotorua, where we conducted this research, and it sort of made me think about the bursting forth of ideas into the atmosphere and into the environment, and sort of made me think about what we can hopefully be doing today. So I wanted to talk about the ideation process. Often in research and in publications, we don't get the opportunity to really talk about that, really the starting place of the work that we do. So it was actually Bridget that was thinking about the checkup self-report and whether Paiarahi or the whānau order navigators could support self-assessment. And so Bridget and others from interRAI had conversations with stakeholders in Rotorua, including older Māori, providers, NASC, whānau members, kaupapa Māori providers, to think about how this might work, whether there was interest in progressing this idea. Then Korowai Aroha and interRAI NZ agreed on a research contract to undertake this work. We recruited Paiarahi to deliver an intervention and also recruited participants to the research, and have done now the evaluation and made some recommendations as a result of this. So Paiarahi are health and community navigators, so they're situated and embedded within the community they work in, have good understanding of the networks available in terms of health and social services, and often have a generalized role in supporting whānau order or whānau flourishing. So we thought about the potential for Paiarahi to be trained up specifically around checkup self-report, and also the services that might come out of an assessment, so what people might access as a result of an assessment or what could support them. And they were trained to complete the checkup self-report. So I want to sort of, I guess, acknowledge that Paiarahi are not a regulated health professional workforce. And so that's different to one of the requirements for assessors in current interRAI assessors who complete all the mandated assessments in New Zealand that result in ability to access aged care services. So they underwent training on interRAI, as well as training on the research processes, and some training about how they would document the referrals and everything. They supported older Māori to complete a self-assessment and then organised wraparound support. Because this was a checkup, a self-report tool, there was the requirement that Paiarahi asked the questions as written in the assessment tool, so the items couldn't be changed. Part of their training did involve understanding the intent of the question, so what, the kind of response they were trying to elicit and why that question was being asked. So that was a big part of their training. But this is a really big point of difference between the current assessor facilitated or assessor driven assessments, where there's the potential to have a conversation, have a look around the home environment, and together with the conversation you have with the person, their family, sort of mark the different levels in each item in the assessment. The decision was made that they preferred, the Paiada, he preferred being able to use a physical copy of the document. It was also thought that if people were completing them themselves, the physical paper copy would be easier than the computer. And there was the incorporation of Māori values and te reo Māori within the assessment and the items. So Māori values were color coded, and then there was a symbol for each of the questions about how, which values the questions or the items related to, and then there was an incorporation of te reo within the question as well. So what's important again is the English version of the question didn't change, but there were often words or concepts in te reo that went alongside each the items, and these were checked by a te reo, a speaker of, first language speaker of te reo from the Rotorua area. So in total, 71 people were approached to participate in this research and 50 people agreed to participate. The main reason that people didn't want to participate was they didn't want to participate in research generally. A few people were put off by the extent of both the participant information sheet and, so that was about 8 pages long. I tried to make it as brief as possible, but HDEC has certain things that need to be included, particularly for an intervention study. And then also the printed assessment itself was 20 pages front to back. So it looked like a stack of thick papers that they had to read through. So we had 50 older Māori participants. The people were eligible to participate if they were 55 or older, and we asked for Māori participants but took a broad approach to Māori, so that if there were Māori whānau living in the same residence or closely with other participants, then that people that were non-Māori, then they could participate too. The age ranged from 56 to 84. 2/3 were female, which is probably slightly more than the portion of females in the population for that age. And generally there were quite low rates of dementia, stroke, cardiovascular disease and heart failure. So for example, only one person had a history of Alzheimer's dementia. And sorry, I should say that reflects sort of the eligibility criteria. People were only eligible to participate in this because it was a feasibility and acceptability study. They were only eligible to participate if they had not had a previous interRAI assessment, were not likely to be someone that you would waitlist for an interRAI assessment, and that they weren't on an interRAI assessment waitlist. So they were generally more well than the people that are currently mandated to have an age-related interRAI assessment for services. So we looked at the acceptability. Most of the items that were asked, people felt were okay to answer. With a few questions, there was some perceived repetition. So just the fact that people were asked what they did, how often they did this in the last 3 days, month, 90 days, that kind of thing. Some questions caused a bit of discomfort, so things like talking about continence. And the self-assessment itself was talked about as being confronting in itself. So people having to really sit down and think about how physically they were performing, how they were performing in terms of their mental health and how they felt. And they found that quite confronting, particularly for people who'd, had this idea that they'd previously been quite well and were now more limited in some of the activities they undertook. And that felt a bit confronting for people. And it was recognised that having the Pai Arahi there to support and that made things better. Some also talked about the fact that they weren't really sure themselves and wanted to actually ask their whānau members what they thought and get a sort of an idea from them before they answered the question. And we did obviously have allowed people, whānau, to be present for these assessments. But one person felt that there wasn't really much, they were doing really well and they just flew through the assessment. So the word koike is the Te Arawa or Rotorua areas, the iwi from Rotorua's word for older Māori. In terms of feasibility, one of the biggest things that was important was the fact that this was used within a connected care team. So Paiarahi were part of a care team. They were connected into clinicians who could action things. It allowed easy referrals and a wraparound of care and also clinical oversight, which they felt was really important. In fact, the care planning aspect so Paiarahi usually do care planning in their scope of practice, but it might be more general and not so much focused on sort of physical and mental health, which this assessment, the interRAI assessment, I guess, lent itself towards. And so they didn't feel that comfortable thinking about the outcomes from an interRAI assessment and what that might mean. Another thing I haven't mentioned earlier is that there was clinical oversight. So each of the assessment was reviewed by the NASC team leader to just check that firstly what had been assessed and the action plan made sense, but also that it had been well documented. So for example, as many health professionals, as many clinicians are trained in documentation and the fact that even if something hasn't happened, we need to document it. So the fact that, maybe this flagged, but it wasn't, the person that was involved didn't want a referral, then the importance of documenting those conversations or documenting the fact that thought had been put into the care, the outcome, even if it was that nothing was to happen. So this is one of the quotes. I think it's really important for people to understand the value-added role of Paiarahi. And I think once the understanding is out there, then there'll be this willingness to embrace it. So this was talking about, for those that don't know the role of Paiarahi and what Paiarahi can do, the importance of that. And that was one of the sort of, I guess, broader outcomes of this work was that NASC and others in secondary and primary care understood more about the Paiarahi role and the importance in supporting koike. So assessment fidelity. So this was talking about whether the items were asked as they were intended to be, well, as they were written. And one of the people we interviewed, so I also haven't talked about that. We interviewed around 15 people after the intervention study, and these were older Māori and whānau and Paiarahi and other providers involved in the sector. And they said that I think the disadvantage of having to stick to that there was disadvantage having to stick to the script. It was kind of a barrier to that flow of the conversation and building of rapport. And so you'll know that, like doing an interRAI assessment, you can generally have a conversation, but if you're having to just go through this very prescriptive script, it does change how that conversation happens. We wanted to examine the use of tikanga and te reo Māori within this. So obviously there were Māori words added and generally people thought that was really important. It highlighted the importance and right of the language to be in these kind of assessments. People didn't think really though that the values needed to be put in alongside each of the items. They felt that was sort of inherent in how an assessment was taking place rather than it being necessarily relevant to an item on the assessment. What they did say though was that, and I sort of alluded to it earlier, was that when it was sort of this assessment, there was always going to be these set questions and things that had to be asked, and so that sort of changed then the way that that Paiarahi would usually practice. So this was one of the comments. It's like a Western assessment. Well, they'd actually said Pākehā, but I've just written this up for an international publication, so I've just changed that word. It's like a Pākehā assessment. So when you're completing that assessment, you look through a Pākehā lens and think about what's available in the Pākehā system. So you close off your world. So they close off that sort of te reo thinking and what you might do otherwise. We looked at the potential for this to support access to healthcare. So 28% of people who, remembering that these were quite a well population in terms of chronic comorbidity and need a known need for an interRAI assessment. So 28% of people were referred to their GP, 2% were referred for a further interRAI assessment, and 2 people or 4% for a further interRAI assessment, and 4% to a rongoa practitioner. And I think this quote, it says, I thought this person needed a formal assessment, so they'll mean a formal interRAI assessment, but actually you could go directly to the occupational therapist. So this was a Paiarahi talking about their increase in knowledge from being involved in this pilot project. So they were able to understand more about the aged care sector and how referrals worked. So that has something, that's a learning that they take forward into their everyday practice now. So that previous slide talked about the referrals. We know with interRAI, generally, there are embedded algorithms that have scales and sort of the clinical assessment protocols that are generated after each assessment. With the Checkup Self-Report, New Zealand, the software New Zealand now now embeds those algorithms, but at the time the Paiarahi were completing this, they did not have access to those embedded algorithms. So they were doing the assessment and then sort of in their minds and talking to the person and developed this care plan. We have applied the algorithms to the assessments retrospectively. And if you go down to sort of the third item, it says assessment urgency, 1 to 6. And so 10 people, so 20% of participants actually had a score that indicates the need for a comprehensive assessment, such as a home care tool. So this is interesting on two fronts. Firstly, because if this had flagged in the embedded computer system, then Paiarahi might have then known to refer that person on for another assessment. So although the assessments were done on paper, the Paiarahi did enter them into a sort of sandboxed, a separate interRAI system that was just for this research after the assessment was done. So they did actually enter it electronically. So we're thinking that this could support Paiarahi in developing their care planning because it's, it's flagging as likely needing an assessment. But also it speaks to the fact that the Checkup Self-Report may actually be really important for identifying those that do need an interRAI assessment. Remember the eligibility criteria were that one of them was that they were not known to need an interRAI assessment and not likely to need an interRAI assessment. Yet 20% of people are flagging as probably needing a further assessment to understand what would be beneficial for them. So what are some future investigations or recommendations? Well, there were mutual learnings from Paiarahi, from NAS services, from healthcare providers, and that was really important for it to be taken forward. There's the potential use for this as a screening tool. So as I said in that previous slide, 20% of people were showing like they probably needed another, an assessment from a trained assessor. And there's the potential for use by other agencies, including NGOs, to prioritise care. And we are writing this up at the moment, so this report has been provided to interRAI services, and we are looking to write a paper for an academic publication in JAMDA as well. So that's on the go at the moment. I wanted to acknowledge the wide project team. So we met at least monthly during this project, and there's a mix of interRAI educators, assessors, those involved in NAS services and interRAI policy nationally, from the Māori health providers, the Paiarahi. And so it really was great to have a team really invested in wanting to push this project forward, and to make sure that the learnings that were had were useful and practical, in the practical environments that everyone was working in. Oh, sorry, and I just want to acknowledge, I've not acknowledged some funders previously. The previous work was funded by interRAI Services, the Paiarahi pilot, and I do want to acknowledge HRC, who are my primary funder through a Māori postdoctoral fellowship. So I am going to stop sharing there. I am not even sure how long I've been talking for, but I assume there will be time for some questions. And thank you to all of my co-authors, my collaborators, my friends, colleagues in the room who hopefully can answer and address those questions. If there is still time in this slot, I did think it would be useful even to just turn to the person next to you for 2 to 3 minutes and talk about something that you're interested in and see where you can find a commonality. And this is an exercise I often do when I'm teaching pharmacists about understanding culture and getting to know someone really quickly. So in a sort of a community pharmacy setting, there's seconds, half a minute to develop a rapport with someone. So there is the ability, if you're intentional in what you're doing, to try and work towards something, a commonality, and that might lead you to other ideas and a collaboration in the future. So thank you to interRAI Services. Congratulations to interRAI New Zealand and International on, the decades of time. And I know that there's been a celebration today for that, for interRAI. And I just want to, acknowledge everyone in the room and thank you all for your time today. Kia ora.